Welcome, everyone, to this exciting panel that we have here today. My name is Mei Kwong. I'm the Executive Director at the Center for Connected Health Policy, which is the National Telehealth Policy Resource Center. I'm joined here today with Dr. Douglas Jacobs, Chris Cowan, and Cherie Gaskins, who are all with the Center for Medicare and Medicaid Services. And we'll be talking about important federal policies that are going to impact the telehealth policy landscape. If we could have the slides put up first. All right, very quickly, a little bit of background about the Center for Connected Health Policy. I mentioned that we were the National Telehealth Policy Resource Center, and we cover a variety of telehealth policy topics. While today's topic will focus primarily on what is going on with Medicare and some Medicaid policies around telehealth, there are a variety of other policy topics that impact telehealth, some on the federal level and some on the state level. So some of that information you can find on CCHP's website. We do cover reimbursement, prescribing, licensure, and consent. And some of these policies are impacted on what is happening on the federal level, but a lot also are happening on the state level as well, too. So depending on what your question is or what your issue that you're interested in, please note that you would need to really look at where it is being controlled by or who is actually implementing policy. It may be the federal government, but it may also be the state government, particularly when you're talking about issues around licensure, around Medicaid policy specific to states, and also things around consent as well too. So please go to the CCHP website if you want to dig a little bit more deeper into those topics. But today we are going to actually cover Medicare and some of the policy issues and policy movements that are happening on the federal level and related to that program. So first off, we will start off with Dr. Doug Jacobs, who is Chief Transformation Officer from CMS. So I'll hand it over to Dr. Jacobs.
Thank you so much. It's really great to be with you here all today. Thanks to HRSA for putting this on. So I wanted to just start talking for a few minutes about some of the high-level topics that we're thinking about related to telehealth at the Center for Medicare, and pass it off to Chris, who is our resident expert on the topic, and he'll go into more detail. So I think, as folks know, during the COVID-19 public health emergency, CMS expanded access to telehealth services to ensure continued access to healthcare as part of what we did in Medicare. Congress temporarily extended flexibilities related to payment for many telehealth services set to expire at the end of 2024. And so CMS has been continuing to examine the impact of telehealth on access and quality. And just last week, we published the proposed physician fee schedule. And there's a whole host of topics related to the physician fees, related to telehealth in the physician fee schedule. And so this year's proposals aims to maintain some important but limited flexibilities wherever possible. And it really reflects our goal to maintain and expand the scope of and access to telehealth services where appropriate. So some specific proposals include allowing certain practitioners to provide virtual direct supervision to auxiliary personnel when required, and also proposing temporary extensions of virtual supervision for a broader range of services when teaching physicians virtually, and when the services are provided by residents in teaching settings. And so a lot of our statutory authority here is dependent on Congress. And so without congressional action, starting January 1st, 2025, statutory restrictions on geography, site of service, and practitioner type will revert to pre-COVID-19 PHE condition policies. And so people with Medicare will need to be in a rural area and medical facility to receive non-behavioral health services via Medicare telehealth. Previously, we have extended telehealth for behavioral health services permanently, so that will remain in effect. And additionally, in this year's physician fee schedule, I wanted to highlight that for the first time, CMS is also proposing coding and payment for FDA-cleared digital behavioral health treatment tools, which we also believe will continue to expand access to behavioral health services. And so really happy to be here with you all today. With that, I'll turn it over to Chris to go into more detail.
Thank you, Doug, and thank you to the partners and HRSA for hosting this event. And I'd like to start out by giving an overview of how you can find out more about what's in the rule. So bear with me here a moment. I'm going to share my screen and then we can get into the actual presentation. So before I go into everything, good afternoon again. My name is Chris Corwin. As introduced, I staff the Medicare physician fee schedule. And the purpose of this slide is just to frame up that I'm here today as your resource, as a public servant giving general explanations of policy. So if you have fact-specific circumstances or need interpretations, please go straight to the source for them. And I'll also point to resources at the conclusion of this slide at the conclusion of this presentation, where you can go and do that if you need specifics. And again, plenty of time at the end for questions, but thanks in advance for holding them until the conclusion of each of these presentations. So with that, I'll get into the specifics of where you can go and what you can do to help us. And again, we appreciate your feedback. What's here before you is a timeline for the notice and comment rulemaking. We do this each year to update rates of payment on the physician fee schedule. So there's a link to the rule. I'll go through some resources as we continue through the presentation about where to look in the rule for certain things. But again, this is just a formal notice that you also now find in the Fred Rule Register. So we really hope that you all consider participation, and thank you in advance for your comments. Please get them in early if you can. The earlier the better, and then we're able to ingest, interpret, and consider further the more time we do have. And so the next slide just explains the conversion factor. This is important for contextualizing what I'm here to share with the group. I'm certainly not an expert in every domain, and I staff a very specific portion of Medicare that basically any separately payable individual service that can be furnished by an eligible practitioner who gets Part B payment may also be eligible for Medicare telehealth. And so they may also be eligible. That's what I'm here to describe and talk about today. And hopefully a key take home point for any of you that are with us today is that Medicare telehealth is a specific set of restrictions with a defined Medicare Part B benefit. So that's the key take home. And that's why I'm addressing things as I will today. But if you want to find out about how we set rates of payment or what's in the rule, I'll refer you to the rule. And again, this slide's just an overview that our rates of payment proposed for calendar year 2025 are now available. And so next to background, I want to talk about what is or is not Medicare telehealth, because there are many definitions of telemedicine and telehealth and remote monitoring, et cetera, that get floated around. But Medicare telehealth in specific is applicable to individual services, as I noted, and we're tied to what we can do under Part B. So as Dr. Jacobs mentioned, there are some opportunities where we can maintain flexibilities, but we do have statutory restrictions and restraints. And so some flexibilities may end, and I'll point that out later in the presentation. But what Medicare telehealth is not, it doesn't describe everything that could possibly be paid under Medicare Part B that involves telecommunications. Again, it's a narrow set of restrictions. I'll go over that in detail, but I just wanted to really frame that up. Now, also, while we are concerned about access, quality, patient safety, within setting payment policy for Medicare telehealth specifically, we're not redefining clinical standards, we're not redefining a scope of practice, and we're not redefining settings of care. We're working across all those. All those are important considerations, but they're not part of our definition or what we're able to influence directly through payment policy associated with what's applicable under the Social Security Act, and specifically Section 1834M, which is colloquially known as the Medicare telehealth statute that we work under. So that's just more context. And if you do want specifics, we codify our regulations, and what I'll discuss with you all today as a group and answer questions about is specifically about regulations that in large part exist under Title 42, 410 78. And so you can peruse that. It's pretty in depth, but I'll try to summarize as best I can our proposals for this year. And again, Dr. Jacobs did a great job of already covering most of what's here. But just to re-summarize, we are amending our definition of direct supervision, which will enable practitioners where virtual care is being rendered for them to oversee their staff who are providing auxiliary services and doing that through interactive communications technology that will allow virtual direct supervision. And that's a continuation of our existing flexibilities. I'll refer those of you who are interested specifically in this policy to the specific language in the NPRM, because it talks about what we're most concerned about and how we're identifying services that we may permanently extend this flexibility and definition towards. So it's really important that we get your feedback. And again, there's an explanation for the rule, which I can also add to if folks have more questions. So new provisional services, just as a general matter, again, there are many resources. This presentation assumes that because of the audience, you all have a basic understanding of Medicare telehealth, which is why I didn't go too far into detail. However, if you're watching this later as a recording or you're wondering to yourself more about the foundational concepts, please go to cms.gov, and our telehealth section walks through Medicare telehealth, including how something is considered telehealth, what the restrictions are, and how something makes it to our Medicare telehealth list, and the steps that one may use to understand what's happening there. But as a result of that process that I just described, and you can find out more about, we've identified that there are some provisional services that we'd like to add to the list. And as well, the status of provisional services from our prior calendar year, we're proposing to maintain those for another year. So the list more or less will look very similar to last year. And so Medicare telehealth, to an extent, will look and feel very similar to last year, with some important distinctions, which again, I'll make a little bit at the end of the presentation. But again, moving really quickly here, because I know the group will be uniquely interested in what's in the proposed rule and what it means for you, depending on your setting of care, et cetera. But if you want more specific examples of telehealth resources, there are some here on the screen before you. The process is described in full on our website, which is a bit more brief, but is exactly the same as we've described over prior years rulemaking. And you can find the list of current services, of which I believe there's now over 265 plus. So there's a lot. I'm not going to go through each one, but there's a variety of services. And as I stated before, you can see what the process is if you think something should be added or removed to the list. And then, of course, not everything is Medicare Part B and not everything is within the Medicare telehealth statute, but a lot's going on in this space beyond what just our team does in effectuating updates to the physician fee schedule. So that's why I wanted to point to useful links. And again, thank our partners that are on the call with us today, because there's a lot of great resources that may apply in general to Medicare Part B, but are really specific to circumstances. Telehealth is very regional and local in many regards. And so to the extent you have specific questions about your geography, I encourage participants to use Mac's resources whenever possible. We also have the Medicare Learning Network, and general questions about payment policy, sort of the why. Please send those to Medicare Physician Fee Schedule at cms.hhs.gov. So with that, another thank you. And I think I've left plenty of time for the next presentation as well as questions after. So look forward to the questions. And again, I'll yield my time. And I think Mayor Sherry may be next.
Just really quickly before Cherie goes on, just want to remind folks that if you have a question for our panelists, please put it in the Q&A, and we will take questions after Ms. Gaskins finishes her presentation. So Cherie.
Thank you. All right, good afternoon. Everyone, my name is Cherie Gaskins, and I am a technical director within the Center for Medicaid and CHIP Services. Specifically, I work in the Division of Benefits and Coverage, and today I will provide an overview of telehealth and Medicaid. Next slide, please. All right. First, I always like to provide a quick overview of Medicaid. I always like to take the opportunity to explain the program wherever possible. Then we will discuss how telehealth can be incorporated into a state's Medicaid program. Next, we will learn about the flexibility and how states choose to implement telehealth. Finally, I'll provide a brief overview of our recently issued telehealth toolkit. Next slide. All right, so I'm sure everyone on this call today, if you've worked anywhere in the Medicaid space, have heard the term. If you've seen one Medicaid program, you've seen one Medicaid program. So in brief, states determine their own unique program within broad federal guidelines. As May discussed at the beginning of her remarks, each state is responsible for developing their program and outlining how they choose to run their Medicaid program. States can choose between a variety of optional services. The federal government does mandate a certain level of mandatory services as well as mandatory populations. But in general, states have a lot of flexibility within broad federal guidelines. Next slide, please. All right, so here's a snapshot of services available for coverage in the Medicaid program. I just want you to know that not all services are reflected in this list. And for a more complete listing, I do encourage you to visit medicaid.gov. But as you can see here, the mandatory services, they are a robust set, and there are many more optional services that a state can choose to add on top of that. Next slide, please. All right, telehealth in short is described as using technology to deliver services. I want to be clear that covered services in Medicaid can be delivered using telehealth. We don't really have so-called restrictions on how telehealth can be used. Medicaid coverage of services delivered via telehealth are not dependent on Medicare rules governing telehealth. As Chris just pointed out, Medicare tends to be a little bit more prescriptive in how telehealth may be used. Medicaid does not have that same sort of specificity. So therein lies a lot of flexibility for state Medicaid programs to design a program unique to their circumstance. Next slide, please. So really, there are four main modalities that are used to deliver services via telehealth. The most common of which is two-way real-time audio video. This is typically what people think of when they think of telehealth. Basically, the provider and patient interacting with video and audio using computers or smartphones, for example. The other three modalities, including audio only, asynchronous communication, and remote patient monitoring. If you're interested in learning more on these topics, we describe these four modalities in detail in our recently issued toolkit, including the potential uses and limitations for each modality. And at the end of this presentation, I'll also provide a link at the end of the slide on where you can find the telehealth toolkit for Medicaid. Next slide, please. So generally speaking, federal laws and regulations don't specifically address telehealth for most Medicaid and CHIP benefits. Because of this, states really have a great deal of flexibility in how they use telehealth. So I really want to stress this point. It is the state's program, and states get to decide how much and how to use telehealth. States can generally choose which services can be delivered via telehealth, the specific providers who can use telehealth, the telehealth modalities that can be used, and the payment rates for services delivered via telehealth. Next slide, please. So I do want to spend a little bit of time on giving a brief overview of the telehealth toolkit. So first, during the COVID-19 public health emergency, CMS issued two telehealth toolkits in the Medicaid program. with an emphasis on how telehealth could be helpful during the PHE. This new toolkit consolidates information from those existing toolkits and makes the information more general, that is relevant for the non-PHE times that we're currently in. We also added information on how states can improve access to telehealth for Medicaid and CHIP services, which was required by the Bipartisan Safer Communities Act. The toolkit discusses the telehealth topics listed here, including telehealth flexibilities under Medicaid and CHIP, and strategies to promote the delivery of accessible and culturally competent care, for example. Next slide, please. Along these lines, the new toolkit includes sections dedicated to discussing how telehealth can be a useful tool for maternal health services, accessing out-of-state providers, and more. Next slide, please. Within the toolkit, you will find sections focusing on various aspects of telehealth. Much of the information I covered previously can be found in Section 1, Telehealth Overview. Section 2, FAQ highlights provides information on common telehealth topics. The FAQs largely reflect the FAQs that were included in the previously released toolkits, though they were revised to be relevant for non-PHE times. The new toolkit also added 4 new FAQs. Section 3 of the toolkit describes trends in states' telehealth policies before, during, and after the PHE. It also goes into detailed trends in 5 states, which I won't go over today, but you can certainly find it in the toolkit if you're interested. Section 4 is by far the longest section of the toolkit, and it goes into detail about how states can leverage delivery of services via telehealth to address health equity. It describes best practices and strategies for improving equitable access to telehealth among specific populations, and describes how states can use telehealth to address maternal mortality and strategies for using telehealth to provide mental health and substance use disorder services. Section 5 goes into operational considerations for states in implementing telehealth. This includes approaches for evaluating telehealth and considerations for integrating telehealth into value-based care models, as well as strategies for conveying information about telehealth to providers and beneficiaries. Next slide, please. And finally, I wanted to mention that the toolkit has a number of tools listed in the appendix that may be useful for states when implementing telehealth in Medicaid and CHIP programs. Next slide. So that concludes my remarks today. For more information, I definitely encourage you to go to medicaid.gov. And there on the landing page, if you click on benefits, and then we have a whole section of our website dedicated to telehealth. And also you'll find the previously mentioned telehealth toolkit, which I highly recommend you read if you're interested in the subject. Thanks for your time today.
Thank you, Cherie, and thank you, Chris. For folks, I've seen your questions that have been put into the Q&A. I just want to say that this is a very complicated topic, and Chris and Cherie provided, and Dr. Jacobs provided a really great high-level overview and some details on what are in the physician fee schedule, what Medicaid programs can do. But it is pretty complex, so they may not be able to dig in deep in some of the questions that have come up in the Q&A. But we'll all try our best to try to answer your questions. If you want to put it in there, we'll take note of them. CCHP will also try to answer them if you want to contact us offline as well too, or forward them on to our panelists if we're unable to answer those questions. The other thing I want to add, having read what was in the physician fee schedule, I do have to give credit to CMS in how they structured that and what they have been proposing, because as Dr. Jacobs pointed out, and as Chris also mentioned, there are things where their hands are tied in what they can do because they're embedded in statute, and Congress would need to act, and CMS cannot do that on their own. But I did get the sense, and this is just my opinion, that CMS tried very hard to try to create a flexible environment in order to try to accommodate what might happen or what might not happen as far as future congressional actions as well. So I do have to give, a lot of credit to CMS for trying to like structure things really to try to reduce the impacts on Medicare patients and enrollees should things really do end at the end of this year with some of the waivers. So with that, we'll get into the questions here. And Sheree, the first one is really for you. And this does come up a lot, I think, sometimes regarding like what Medicaid programs are supposed to do with telehealth. And the question is, is there like a mandated minimum that Medicaid programs have to do with their telehealth coverage?
No. So that was an excellent question, and that speaks to the variability that I discussed earlier. There's no minimum or there's no mandate from the federal government on Medicaid programs to cover telehealth.
Mm-hmm. Yeah, states have a lot of flexibility, and as Sheree said, if you look at 2 states, you're going to see like very wide differing policies on how they address telehealth in their Medicaid programs. Thank you, Sheree. We have a question for you, Chris. It's 2 parts, so I'll give you the first part first. It says, as a mental health provider, I have 2 primary concerns. One is requirement for in-person annual visits, nearly impossible for majority of patients. And also 2 is also requiring reimbursement equality parity for telehealth visits versus in-person visits. Many insurances are saying they will pay less for telehealth visits as well as require members to use only certain platforms that may not be used by providers.
Excellent two-parter, and I'll take it in 2 parts as well. And first, set down foundationally what the statute says and what our regulations say and where that comes from, and then hopefully address the concerns. But again, thanks for the question. First, to the matter of in-person visit requirements, and again, many experts, including in the audience, so I could be over-explaining here, but the CA 2021 basically made the home an eligible site for a Benny to receive healthcare services for the purposes of treatment and ongoing diagnosis and management of behavioral health issue, including substance use disorder. So what that means is that opens a permanent set of expanded telehealth options, which we've discussed, but it also included a requirement about an in-person visit at a certain interval, and first being within 6 months of the initial service, i.e. for a new patient, and then subsequently 12 months, each 12 months for an existing patient. And it's been CMS's position in previous rulemaking that we would delay that requirement. There is some discussion in the proposed rule specifically for RHCs and FQHCs about how they intend to handle that. And so I'll point folks there about the specifics, but there's only so much flexibility. But again, I don't want to go too far. It's better to go to that piece of our rulemaking and respond to the comment solicitation. But again, it's been the agency's position to have as much flexibility as possible. We've not implemented those requirements. We've spoken in previous rulemaking about them and about why we were delaying. So I'm sorry that I can't offer more definitively, but then the next piece is about payment parity. I want to be really specific and careful here. This is just about setting rates of payment for telehealth versus the equivalent in-person service. And it's been our longstanding interpretation and implementation of the telehealth statute that we pay an amount equal to had the service been furnished in person. So I'm very careful with my wording there, but that's been the policy all along. There may be variations or things around the edges based on setting of care, different services, but when it's the same service, same setting of care, same practitioner, all things the same in person versus telehealth, we pay an amount equal to. So there's parity in that regard. So hopefully I addressed both those questions, probably the latter more head on, but anything else or follow-ups?
All right, thank you, Chris. Sheree, audio only became big during the pandemic and it's been actually incorporated in a lot of state policies as well. But, folks have questions. Can Medicaid programs cover audio only?
Yeah, so Medicaid programs definitely have the flexibility to cover audio only. And we talk more about the audio only stance in our telehealth toolkit. So another plug for the toolkit.
Again, you got to check with your state, so it's going to differ. Chris, this is actually a pretty specific question. It was about something that was on one of your slides. Could you clarify, well, permanent amendment to definition of audio, video, and audio only, specifically third bullet on his slide stating practitioner must have video capability and maintain capability. Does this third bullet statement imply provider must maintain the video capability even when the patient can only connect via audio only?
In brief, that is the intent of the policy, an excellent pickup, because it's meant to be at the beneficiary's need. And that could be pieces of clinical and practical, right? In beneficiary preference. And so that's why I'm being careful here, but it is not the intent of the policy that the clinician would not be able to offer it to the beneficiary or to put certain roadblocks in place that make it more difficult for the beneficiary to have access. That's not the intent of the proposed revised definition. So again, I encourage comment here because we are in the comment period, but I did want to take the opportunity to clarify it's not the intent of the policy to limit beneficiary choice in any way or access to that modality. It's simply to give a flexibility that when they don't consent to or they're unable to, that they don't use, they don't need to have both audio and video in that instance. Does that make sense? Did I clarify enough? May I'm looking at you just to make sure.
I think you did. We got a thumbs up from the audience. So hopefully
okay.
That was whoever asked the question there.
Fingers crossed. Okay.
Okay. I'm going to combine a couple of questions here because they all are asking about originating site. I think this is directed to Chris, but Cherie, if you want to weigh in on like, what Medicaid programs to do as far as selecting what are eligible originating sites. There are a couple of questions wondering if home will still allowed to be like an originating site. So I don't know, Chris, if you want to take that from like Medicare perspective, and Cherie, if that's something that you've seen a lot with like states and Medicaid programs, if you want to weigh in on that.
Yeah, I can briefly say that as flexibilities expire, only the permanent piece, and that's why I answered with the statutory authority as well, that for purposes of behavioral health, which includes treatment for substance use disorder, home is an eligible originating site, but not for non-behavioral telehealth. And I know that's a double negative. That's why I did it at the end, but without further action from Congress. But that's an easy summation, and I'll pass it over to Cherie.
Sure. Thank you, Chris. And this is part of why I included in my slides about the Medicaid state Medicaid programs are not tied to the Medicare requirements for telehealth. So, and we run into this issue quite a lot in terms of states coming to us, and they'll say, well, XYZ type of provider, we would like to make them originating site or a distant site or something like that. And we always say, you have the ability to do it. You are not bound by Medicare requirements. There's nothing in the Medicaid statute that will, oftentimes when we're trying to assess what rules to use in order to evaluate a state's question, we look to the statute and our regulations. And there's no statutory basis that says a state Medicaid program is tied to the requirements found in Medicare for telehealth. So a state has a lot of flexibility. Just because a thing is true in Medicare does not mean that the Medicaid program has to follow suit. Now, having said that, many states find it useful, helpful to follow Medicare because Medicare is, as we all know, it is huge. Medicare has a lot of rules and requirements around it, and states don't have to create their own rules. They can just piggyback off of the Medicare program. So we find that when we get those types of questions, typically a state has modeled their program after many of the policies and requirements that were listed in the Medicare program. And we have to remind that state, no, you actually have the flexibility to change it if it doesn't serve you any longer. So excellent question. But again, states have flexibility.
Yeah, that has always been one of the great things that we've seen, like where the Medicaid program's concerned, is that CMS does give so much flexibility to the states to like craft what their telehealth policies looks like in their program. Lot of questions. Again, I'm going to combine them around FQHCs and RHCs, and really the big one that I'm seeing frequently is being asked is, will they be able to continue to act as a distance site provider? And again, this is probably a question that could be applicable to Medicare. I think that's like on a lot of people's minds as well. But Sharif, you want to talk about FQHCs and RHCs being distance site providers on the Medicaid level, please do so. So Chris, why don't you start us off, like FQHCs and RHCs, what are the possibilities of them continuing to be a distance site provider?
Yeah, and this is one where I did pull a page from the rule because I do want folks to respond to the RFI about this. Flexibilities will expire. Here is one where that may be the case, and information and responses as part of notice and comment rulemaking are very helpful to us. We talk about telehealth reimbursement rates and finding an appropriate way to calculate rates. And for purposes of FQHCs and RHCs, there's a specific approach that takes a blended averaging and weighted volume of everything that's on the telehealth list and assigns a G code for billing. So that's one aspect of it. But please go to, it's now on the display rule. I think it starts at page 528 of the rule. But we explain more in detail what we hope to achieve through a general RFI about appropriate rates. But that is the other piece too. Once we get to post expiration of the flexibilities that exist now, RHCs and FQHCs could not be paid for non-behavioral health services that are furnished remotely to bennies in fee-for-service Medicare after December 31st, 2024. So just want to be really clear about that. But the information that you may share during the comment period would help us out a lot.
And I'll just same answer as before. FQACs and RHCs are not, in terms of their participation, as originating a distance site, they're not, for the Medicaid program, bound by the requirements established in Medicare. So again, states have discretion and flexibility.
For folks who aren't familiar with it, the acting as a distance site provider, CMS is bound by what's in federal statute. There's actually a fairly specific list, and FQHCs and RHCs are not on that list. So they just can't automatically make them eligible distance site providers. That again is something they have to wait for Congress to like make a change in federal law for them to do that. But in that sort of section that Chris was directing you to, and Chris, not to put you on the spot or anything, so you don't have to respond to this if you don't want to, but I noticed that there was a call for comments on possibly adding or in expanding the current definition of what a visit might mean for FQHCs and RHCs. This is not a proposal that's in the current physician fee schedule, but a request for comments and possibly going beyond sort of mental and behavioral health for FQHCs and RHCs. So that's something a little bit of a different approach. It does not make FQHCs and RHCs eligible telehealth distant providers, but it may make the technology, if this is something that happens in the future, available to FQHCs and RHCs to provide services. So again, go and read that in the physician fee schedule. And if that's something you're interested in, you need to provide comments to CMS, some feedback and information to them as well. Again, it's not a proposal, it's a call for comments on that specific issue regarding a redefinition for visit. So, all right then. Great questions from folks. Another thing, Chris, that we've come across as like a technical assistance center on telehealth policies is there's still some confusion about point of service codes 10 and 2 and when to use them. I don't know if you're able to provide a little bit more clarity on when those are supposed to be used and like sort of like what's the impact of using them.
Thanks for the question, May. And I can, and I'll also say that the Medicare Learning Network also has some materials. But in brief, I'll just address individual practitioner submitting a bill. So if you have specifics or something deeper than this, please follow up with questions or refer to the resources. But in general, the intent of the policy that we explained in last year's rulemaking was that we had this flexibility. We had sets of services that happen sometimes in facilities, sometimes not. And there's two separate rates of payment for those services at times. And again, I refer you to the rule because you can see what may have a different facility or non-facility rate. But in basic sense, you use place of service 2 when it's in a place of service that's telehealth other than the home, and place of service 10 is for the home. I will say that it was a bit confusing by CMS, and thank you for bearing with us, but we've clarified. In previous years, it wasn't clear whether we'd modify place of service or modifier codes to do this, and there was some changing and thinking, but that's the policies it sits. So then, in addition to using either POS 2 or POS 10, depending on circumstance where you're located, you would append an appropriate modifier. And so Sheree might speak more to this, but there are situations and circumstances where different systems and programs use different modifiers, but in general, the modifier as appropriate for your system and how you bill. So there's a little bit of variation we could go into, but generally place of service 2 or 10, modifier 95 or 93 to delineate whether it's audio and video or audio only. That's a general rule. But again, please be careful with specifics and ask a MAC if you need specific billing guidance.
Actually, I see a couple of questions regarding consent and sort of when do you need to get consent, and also how often should practitioners be obtaining consent from their patients on using telehealth?
Yeah, and again, this gets a little bit farther outside the scope of telehealth, so I want to be careful. I'm giving you a general rule and a principle here, but that consent once a year and keeping that available is fine. And it all assumes, again, that with patient onboarding and establishing that patient relationship, that the considerations important to beneficiary access, choice, and informed consent have been built into the practice approach. So that's my general remark to say, be careful. I think as long as it's reflected and documented, it's okay. And in certain circumstances, consent for a subset of services, and if this isn't specific to telehealth, needs to happen sometimes before the visit, but in most cases, again, as a general, at the time of the visit is okay as well. It just depends on what the service is, what the pairing is, and what the clinical circumstances are. But as a general rule, once a year, it can be obtained by auxiliary personnel or support staff, and as long as it's reflected in the medical record, even at the time of the visit, is sometimes okay.
And Sheree, I don't think CMS requires or has that as a specific on consent for Medicaid programs that they have to have some sort of consent policy for telehealth.
Not for telehealth. I mean, I think generally there's consent for services. And since telehealth in the Medicaid program is not a service, but yet we view it more in the Medicaid side as a delivery system, which is why there is no statute, regulations, that sort of thing, which is how we get to flexibility in the Medicaid program. So when we talk about consent, it's going to be whatever the state's established general consent requirements are. There's nothing, at least from the federal Medicaid program, that we establish as consent. So I think that's more of a state implementation question. That's best answered by the state. So
yeah. And And just to warn folks, again, this is a state by state scenario. Some states do have that embedded in their state laws that you would need to get like a prior consent as it relates to telehealth, and some just have it in their Medicaid policy. So again, it can get very confusing. So you need to like check the specific state. And sometimes you have differing requirements or elements that they may want you to include in the consent form, and it may differ what's in statute and what the Medicaid program may ask for. So again, you just have to be careful, and depending on who your patient is covered by, you just got to check their policies to be certain. Um, Chris, there are a couple of questions regarding this in that, a bit of a two-part, but kind of going towards the same thing, I think, is when do you expect the final rule to come out for the physician fee schedule proposals? And also, when do they go into effect?
Excellent questions too. From a process standpoint, typically CMS would finalize a rule and it would be effective 60 days after posting. So if you back up to the normal effective date for any given calendar year, it's going to be January 1, 2025. The rule for calendar year 2025 would be effective then. We'd look 60 days before that to get a final rule out and set the schedule. Sometimes there can be extenuating circumstances or pieces of legislation that may come late and alter those timelines. So that's why I'm kind of wiggling out of giving you a precise date, but that's usually how things happen. We work back from the effective date, the first day of the year that the fee schedule needs to be effective, 60 days prior to that for adequate notice with the final rule. And that gives you a sense, but we'd like all comments in by mid-September. And so that kind of gives you that 2-month window where the staff will be working to issue a final rule.
Yeah, I think, Chris, your deadline for this is September 9th.
To receive comments, yes. Yeah, comments, and that not promising you a date on the final rule. I just wanted to be clear, but yeah.
Yeah, and actually that kind of leads to a question that, it's touched upon a bit, like a couple of questions that audience members have put. What will happen, let's say, if Congress does pass a bill and extends the deadlines, but puts like another caveat on, of the extension of the deadline? Let's say that comes down in November. What's sort of like the administrative actions that CMS would have to take to accommodate sort of like any legislation that comes down that might kind of alter what you have done through the physician fee schedule? And what's that type of timeline? And I know this is all hypothetical, so you don't have to, give us details, but what is sort of like that process for you guys?
Understood. I think it may look like an IFC, so an interim final rule with comment period that would implement whatever piece of the physician fee schedule that may be altered by possible subsequent legislation. It may look like that. I can't admit to being an administrative law expert myself, so I don't know about what must we do in those circumstances, but usually the statute gives us a good idea of what we do. And in prior circumstances where like scenarios have occurred, Congress has given us program instruction authority to implement in absence of full formal rulemaking. So it depends. It's context specific, and the context is really important here. And so if Congress gives us something that's last minute, but also gives program instruction authority, then there are some judgment calls, and that's kind of for the agency to handle as it comes. And so that's as far as I can go in the hypothetical, but that's one set of possibilities.
Okay, no, thank you for providing that, because I'm sure that's at the forefront of a lot of people's mind of like, what happens if something not conflicting, but changes sort of the path of what the physician fee schedule proposed. Cherie, I think this might be for you. If Medicare does not extend the non-behavioral telehealth waivers that are existing beyond like the end of this year, but a state wants to, does the state need to file a state plan amendment? a waiver of some sort, and will the FMAP be paid by CMS for telehealth services done by Medicaid providers for states that want to continue telehealth for non-behavioral health? A lot of elements to that one. So
Yeah, and
I think
I'm
it
gonna try
boils
to.
down to like if the waivers aren't like, extended on the federal level for Medicare, what happens with a state? Do they have to like follow that?
No, in terms of telehealth, and I realize there are some other waivers that were done during the PHE where Medicaid was specific to, but we're talking about telehealth in general. Recall that the Medicaid telehealth policy, even prior to the PHE, was flexibility. So we were never bound by Medicare. So if Medicare's waivers go away, or whatever they do in the Medicaid program, it is not Medicaid, state Medicaid programs are not bound to that. So it doesn't matter. It really just matters how the state wants to structure it. And like I said, many states do decide to follow Medicare requirements, but they do not have to, but they could. And so just to be clear, a state Medicaid program is not bound to Medicare and how they implement telehealth.
A part of that question too, and I think there's a lot of confusion around this, is do they need to file a state plan amendment when they're doing their telehealth policies?
So that's a great question, and we actually have the answer available on Medicaid.gov if you go to the telehealth section, but I'll answer it now. You only need a state plan amendment when the state is paying differently. So if the state, let's just pick any old physician service, some primary or preventive care physician service, if they are paying the same amount for in-person as well as through telehealth that they would normally pay, then there's no need for a state plan amendment. A state plan amendment is only necessary when they want to change the payment methodology for that service delivered through telehealth.
This is kind of like on that same track in a way. So whether Chris or Sherry, want to answer this, but it's, do Medicare restrictions on the type of services allowed via telehealth impact patients using telehealth with private insurance, or Medicare patients who would like to pay purely out of pocket for a telehealth service not permitted by Medicare?
I can say that that's a reasonable position that's been shared through comment letters that we've received before. And it's conjecture about whether or not, but unintended consequences are an important consideration in any of our policies. And so we weigh those heavily, but I can't answer that on point because that's not specifically what the Medicare telehealth list exists for example. That's not why 1834M is defined and codified in statute, and we have regulations about, and that's not what we're regulating when we're issuing our policies. But again, it's an important question, and it's one that others have asked.
Yeah, if for private insurance, again, to kind of echo what Cherie was talking about, it's going to depend on your state. So for private insurance, a lot of the states, actually the majority of them, have some sort of state law, sort of basically saying what private insurance companies are to do with telehealth delivered services, and what those requirements are. Again, like Medicaid program, they differ. There's a large range between the states. So that's where your private insurance is. For if you're paying out of pocket, it's a little bit different. There are other things that kind of impact that, such as like licensure laws and privacy laws, et cetera, et cetera. But the Medicare program really wouldn't, I don't think their policies would apply to that if the patient is like paying for something themselves directly, the entire visit, for the entire visit there. All right. We are quickly reaching the end of our session here. We have 5 more minutes, so we can take a couple of more questions. So again, if you have any last minute questions, please put it in the Q&A here. But kind of, and Chris, I don't think this was under your area, so I don't know if you can answer it, but people were asking about, there's this question here about Medicare Advantage and what they need to do with telehealth. So I don't know if that's like in your area to like speak on or not.
I'm not an expert, and that isn't my area. However, I will say there's greater flexibility under that program than we have under traditional fee for service, and that is true. And recently, as I requested, we do during the comment period request information, particularly analyses of the impact of telehealth. And one of the most recent ones that we've reviewed and is now publicly available was a publication um, trying to isolate the impact of what Medicare Advantage did first in terms of their flexibility to sort of quantify the impact, but that's the extent of my awareness. So they have more flexibility and it's permanent. That's a broad and general answer to that question.
Cherie, follow up on the spa question. If a state spa says they follow Medicare, then would a state spa be needed if the state wants to continue past December 31st, 2024? The end of the
Absolutely. Absolutely. It would be needed. And let's be clear, it's needed because they filed a state plan amendment with us saying this is how they do it. And so anytime there is a change in how the state is operating their program, they would need to submit a state plan amendment to make that change. So that's why it's needed. Not so much that they're doing their own thing, but because how they told us they're doing it is now counter to what they stated in their state plan amendment. So that's the reason that a state plan amendment would be necessary.
Another question about Medicaid. They're asking that if a provider or patient is located in another state, do we follow that state's Medicaid process?
Yes, because that state would be the payer.
All right, then. We can probably take about like 1 or 2 more questions here because we only have about 3 minutes. Let's see. A couple of these, I did combine your questions here, so I'm trying to see if there is anything here that we did not touch upon.
May I address it's one question I saw that I would like to just be very clear on, and it was whether the question was, will Medicaid ever require states to allow telehealth for behavioral health? And I just want to be clear, that is not a federal Medicaid position. Remember that all states have the flexibility to allow telehealth for any service. So if that is something you're experiencing, that might be within your state, how they've decided to implement telehealth, but that is not a sort of, from our perspective, from the federal side, a state has flexibility to allow any service practically to be furnished via telehealth.
All right, we're going to take one last question. And as moderator, I'm going to exercise moderator privileges here because I saw a couple of telehealth research centers ask a question. And this is something that we've encountered in that what happens when there are differing answers that we received from MACs. And for those who are not familiar with what MACs are Medicare administrative contractors. They're kind of they cover like the area, certain states, and practitioners actually send in their claims, I think, through them, then they process it. We sometimes encounter like different MACs giving different policy answers on Medicare. And so our question is there a way or a person that we should contact at CMS if we encounter that? Not only to like get sort of like, well, what is the answer, but that there are differing like answers that we're receiving.
Yeah, that's important information to us, and Medicare physician fee schedule at cms.hhs.gov as well. But again, thank you to the asker and inquirer. I'll likely follow up as well after that, because that's important. When there's inconsistency, we want to know as soon as possible.
All right, great. Well, we're at the end of our session here. So once again, I just want to thank, Dr. Jacobs, Chris, and Cherie for this really great presentation. Thank you also for the attendees for the wonderful questions that you had here. We learned a lot today. It is complicated. We did not get to everybody's questions, but I believe that they are being downloaded. I'm not sure. There was a question of whether the slides would be made available or not, and I'm actually not quite 100% certain about that. But I'm sure that the attendees will be informed if they are made available later. So thank you, everyone. And thank you also for HRSA for hosting this and providing us all an opportunity to speak to you today.